Good morning, everyone. Very warm welcome to all the delegates who have participated in this session. Myself, Dr. Vishal Sharma. I'm an interventional cardiologist. I work as an associate professor at UN Mehta Institute of Cardiology and Research Center. We'll be talking about pulmonary arterial hypertension and its current management. So the next 30 to 40 minutes, we'll be talking about the updated definition of pulmonary arterial hypertension, the pathophysiology behind this disease, the risk assessment in these patients, the therapy that is available for these patients, whether to go for mono or combination therapy. Finally, we'll review some pivotal trial and finally end up with a nice interesting case. So PAH was initially defined way back in 1973 in Geneva when the World Symposium on Pulmonary Hypertension, this body met in Geneva in 1973, and they defined pulmonary arterial hypertension as mean pulmonary artery pressure more than 25 as assessed by right heart catheterization at rest. Now we have come over a long time and this definition was recently revised. The World Symposium on Pulmonary Hypertension, they again met at NICE and they redefined the definition. Now pulmonary arterial hypertension is defined as mean pulmonary artery pressure of more than 20, a PVR of more than 3 and pulmonary artery wedge pressure of less than 15. So why this revision in definition? Did we require this revision? Yes. Well, over the years, they have found that when we see the pulmonary arterial pressure in normal patients, most of the normal population had the pulmonary arterial pressure of around the mean pulmonary arterial pressure of around 14 plus or minus 3. So if you take 2 standard deviation, most of the normal individuals, they have a pulmonary arterial pressure of less than 20. Hence, the people having pulmonary arterial pressure, mean pulmonary arterial pressure of more than 20 were included in the definition of as having been pulmonary arterial hypertension. So does this definition benefit? Well, it doesn't change the management as such, but yes, you can include more and more patients with disorders like connective tissue disorders or those having HIV or portopulmonary hypertension or those with pulmonary veno-occlusive disease. These patients, more and more patients can be included in the definition of having pulmonary arterial hypertension and hence benefit from early treatment and early diagnosis and treatment. Also, I would like to point out that the World Symposium on Pulmonary Hypertension, which met in NICE, they also clearly classified pulmonary arterial hypertension to 3. So now we have this pre-capillary pulmonary hypertension, which is defined as mean pulmonary artery pressure of more than 20, pulmonary artery wedge pressure less than 15, and PVR of more than 3. Then we have this isolated post-capillary pulmonary hypertension, which is defined as mean pulmonary artery pressure of more than 20, a pulmonary artery wedge pressure of more than 15, and PVR of less than 3. Finally, we have this combined pre- and post-capillary pulmonary hypertension, which is defined as mean pulmonary artery pressure of more than 20, pulmonary artery wedge pressure of more than 15, and PVR of also more than 3. So this is how the World Symposium has clearly defined and classified pulmonary arterial hypertension, which was not available till now. So this update is recent, and you need to keep this in mind. Now, a word about the pathophysiology. We all know the pathophysiology of pulmonary arterial hypertension is very diverse. It involves this intimal proliferation and fibrosis, there's medial hypertrophy, there is vascular remodeling, there's vasoconstriction, there's thrombosis, and there are plexiform lesions. And all these factors together play the major role in causing pulmonary arterial hypertension. As far as the cellular changes are concerned, we know there's endothelial dysfunction, ultimately intimal fibrosis, medial hypertrophy. This leads to plexiform lesions and thrombosis, and that leads to pulmonary arterial hypertension. As far as the classification is concerned, this is the conventional classification or the classic classification that we call. There is an entity called known as the primary pulmonary arterial hypertension, in which there is no other pathophysiology involved. It's the pulmonary arterial system which is affected, and there is this secondary pulmonary arterial hypertension, in which we have other factors playing the role in pulmonary hypertension. The WHO has also given its own classification. According to WHO, the pulmonary arterial hypertension is divided into 5 groups. We have the group 1, which is also known as the pulmonary arterial hypertension. It includes the idiopathic pulmonary arterial hypertension, the familial entity, and the associated PH, the PH associated with HIV or connective tissue disorder or other sorts of infection. Then we have the group 2 pulmonary arterial hypertension, which is due to left heart diseases. Then we have the group 3 due to lung diseases. We have the group 4, that is chronic thromboembolic pulmonary hypertension, and finally we have group 5, which is the mixed disorders or the miscellaneous disorders. As far as the treatment is concerned, we all know treatment is very well defined and has changed the prognosis in patients with group 1 and group 4 pulmonary hypertension. But yes, I would say the treatment is less defined and less rewarding in patients with group 3, 2, 3, and 5. So this is clear. Group 1 and 4, we have a definitive therapy, and prognosis has changed, the survival has improved. But for group 2, 3, and 5, I think still the treatment is very less clear if the patients develop pulmonary arterial hypertension. As far as the symptomatic classification is concerned, we have this NIH or WHO classification, which classifies the patients according to symptoms into 4 classes. The class 1 is those patients who are completely asymptomatic, the class 2 patients who have symptoms on regular activity, class 3 who are just comfortable at rest, and finally we have the class 4, those patients who also have symptoms at rest. So how do you diagnose pulmonary arterial hypertension? You need to have a very high clinical suspicion if you want to diagnose a patient with pulmonary hypertension. So if you have, any symptoms suggestive of pulmonary arterial hypertension, you need to get a few basic tests done. And this flow chart, this was given by the European Society of Cardiology. This is very nice. You can just follow this flow chart and reach a proper diagnosis in patients with pulmonary arterial hypertension. So you need to have a basic test done. You need to take a detailed history, some basic examination, ECG, echo, a pulmonary function test, an X-ray, and a CT. So when you get these tests done in any patients suspected of having pulmonary arterial hypertension, you will reach the diagnosis whether the patient has group 2 or 3. So if any of the tests is abnormal, that is, you can find any echo abnormality in the left heart system, or X-ray or CT suggestive of any lung parenchymal disease, you can clearly say whether the patient is having a group 2 or group 3 disease. If all these tests come normal, you can further go for a ventilation perfusion scan, and this will help you in diagnosing the group 4, that is CT-PH. If that also comes out to be normal, that is a point you need to refer to the patient to a PH expert center. We here in the Western India are one of the PH expert centers, and most of the patients from the periphery and from different states are referred to this center for further management. So it is at this point that we come into play. Most of the tests are done, the echo is done, the CT is done, and the ventilation perfusion scan has also been done, and the cause is still not known. At this point you have to apply certain basic tests, the further basic and advanced tests, to diagnose really what is the cause of pulmonary arterial hypertension in these patients. So you need to have, you can get a CT pulmonary angio done to know, say, pulmonary vein occlusive disease or pulmonary capillary hemangiomatosis. You should see the drug history of these patients, any toxins. You should rule out infections like HIV, HBsAg, HCV. At the same time, autoimmunity. You should get a detailed ANA profile done, or any other specific tests for connective tissue disorders. Finally, genetic analysis is also available. If all these tests come out to be normal, you have to go for the genetic analysis, which we here go and diagnose idiopathic or familial pulmonary arterial hypertension. This talk was majorly, this talk would be, further would be majorly dependent on the group 1 patients. So we'll be concentrating more on the group 1 patients, because these are the patients, these are the serves as an orphan disease. Most of the physicians and, they misdiagnose, or these are the patients which are less attended to. So our further talk would be more concentrated on patients having group 1 of pulmonary arterial hypertension. As far as this group 1 is concerned, it's a rare disorder, and it has an incidence of around 3 to 4 per million cases per year. And females are more likely to have this disorder, 3 times more likely, in fact, to have this disorder as compared to adult males. I would practically say in our institute also, and in general, other forms of pulmonary arterial hypertension are far more common as compared to this group 1 patients. As far as the symptoms of these patients are concerned, I think they have these basic symptoms of dyspnea, fatigability, syncope and pre-syncope, and palpitation. So these are the basic symptoms these patients have. These patients might also have ankle edema and other signs of right heart failure once the right heart failure sets in. So till the right heart failure works well, right heart function works well, they have less symptoms. But once the right heart fails, they ultimately have features of right heart failure. So how do we treat? What are the goals in these patients? So when these patients come, our aim is to improve their survival, improve their quality of life, improve the RV hemodynamics, and improve the exercise capacity as measured by the 6-minute walk distance and the WHO functional class. So let's see what are the treatment options, the treatment strategies, the treatment agents that are available with us for the treatment of patients with pulmonary arterial hypertension. Despite the fact that, over the past decade there has been really improvement in the fact that we have so many trials, so many newer drugs during the armamentarium of the drugs we already had. Despite that fact, the annual mortality of patients with pulmonary arterial hypertension really remains high, and that is around 15%. This is the Western data. In India, it's slightly more higher. So annual mortality has still remained high. The main cause because, as I said, it's a right ventricular failure. So how do we improve the prognosis, the overall outcome in these patients? Despite the fact that we have so many drugs, the outcome is not so good. So how do we improve the outcome? So to improve the outcome, there is a strategy known as the risk stratification of patients presenting with pulmonary arterial hypertension. So this is really important. I think all need to take care. The physicians attending the patients with pulmonary arterial hypertension, they need to be aware about the risk stratification of patients. So you have these 12 points which can be divided into 3 major categories. That is the clinical condition of the patient, the exercise capacity of the patients, and RV function of the patient as assessed by the cardiac markers or MRI or right heart catheterization. So 3 main categories. That is clinical features, exercise capacity, RV function. 3 main categories as assessed by 12 main points can really stratify the patient into either low risk, intermediate risk, and high risk. This risk stratification is really important because the further management of the patient depends upon this risk stratification. It depends whether the patient falls into low risk, intermediate risk, or high risk. So the first point, this is the first step. As soon as the patient is diagnosed with idiopathic pulmonary arterial hypertension, you have to risk stratify the patient. This is the first point in the management of pulmonary arterial hypertension. Now, treatment algorithm as far as concerned, before starting the true treatment algorithm, you need to note that the general measures and the supportive therapy, they play an as important role as the specific therapy in patients with pulmonary arterial hypertension. So general measures include the vaccination in these patients, the pneumococcal vaccine, the influenza vaccine, proper counseling. This is very important. Patient require a proper counseling because this is an orphan disease. Not many patients know about it. So you need to counsel the patients properly. A proper exercise training is required and supplemental oxygen SOS. Supportive therapy, this includes the use of diuretics, long-term oxygen therapy, anticoagulation, ACE inhibitor, ARB, and beta blockers. So these supportive therapy and general measures, they play as an important role as the specific therapy in patients with pulmonary arterial hypertension. Now, going to the specific therapy, now we'll dive into the specific therapy for pulmonary arterial hypertension. The specific therapy for pulmonary arterial hypertension is basically based on 3 pathways which play a major role in the disease process. So there are 3 pathways, major pathways, and most of the specific therapy as available now is based on these 3 pathways. The first pathway is the endothelin pathway. So basically endothelin is a very strong vasoconstrictor and also a fibrotic agent. Its level are increased in patients with pulmonary arterial hypertension. So we are using endothelin receptor antagonists. The concept behind is, endothelin receptor antagonists will antagonize the action of endothelin, ultimately cause vasodilatation in the pulmonary arteries and also reduce the fibrosis. The next pathway is this nitric oxide pathway. Again, because of the endothelial dysfunction, intimal fibrosis, the nitric oxide levels are really reduced in patients with pulmonary arterial hypertension. So the nitric oxide levels are low. So what you can do is you can either reduce the degradation of nitric oxide by using phosphodiesterase type 5 inhibitors, or you can increase the level of production of nitric oxide by agents such as soluble guanylate cyclase stimulators, which is riociguat. So this is how you can increase the nitric oxide level and act on this pathway. The final pathway is the prostacyclin pathway. Again, intimal fibrosis and dysfunction. Prostacyclins are actually produced from arachidonic acid if you go back to the biochemistry classes. So because of this intimal fibrosis and endothelial dysfunction, you have less of prostacyclin in these patients, and hence you can increase the level of prostacyclin by either adding exogenous IV prostacyclin or adding some agents which can act on the receptors of prostacyclin like selexipag. So as we discussed, there are 3 pathways. So as of now, we have 3 major group of drugs. The drugs acting on the endothelin receptors like the bosentan, ambrisentan, macitentan, which are given orally. Then we have drugs which affect this nitric oxide pathway, which includes sildenafil, tadalafil, and riociguat. Riociguat is a soluble guanylate cyclase stimulator, while sildenafil and tadalafil they inhibit the phosphodiesterase enzyme. And finally, the prostacyclin pathway, which includes the IV prostacyclins and an oral selexipag, which acts on the receptor of prostacyclin. So this is how the specific therapy for pulmonary arterial hypertension has been divided into 3 major groups. It is based on the 3 major pathways which are involved in the pathobiology of pulmonary arterial hypertension. So now let's dive into the algorithm. So this was proposed by this World Symposium on Pulmonary Hypertension, which met in Nice in 2018. So whenever you have a patient who has been diagnosed with pulmonary arterial hypertension, you need to refer the patient to a expert center. Now this is the first point. This is the point which has been really stressed upon during this meet. So whenever a patient is diagnosed with pulmonary arterial hypertension, you need to refer the patient to a center which is, which is managing patients with pulmonary arterial hypertension. Here at UNMICCE, we serve as an expert center for the Western India for pulmonary arterial hypertension. As I said before, the treatment starts with the general measures and the supporting measures. And then the first step in assessment at an expert center would be testing the vasoreactivity in these patients. Now, I think I need to make you all aware that this point, vasoreactivity, is really catchy. But make note that very less number of patients are really vasoreactive. So what we have found, and what most of the centers around the world have found, that only 5 to 10% of all the patients that are referred to the expert center have vasoreactivity, and you have to be really careful to define vasoreactivity. Vasoreactivity would be defined as the mean PA pressure falling below 40, the fall in PA pressure is more than 10, and the cardiac index has improved, the pulmonary cardiac index in fact has improved. So all these criteria have to be met in right heart catheterization before saying that the patient is vasoreactive, and only this group of patients has to be put on CCB. So it's a very small population, and you need not put other patients on CCB. That in fact can be detrimental. Why? Because the disease progress will continue, and secondly, a failing RV would not tolerate CCBs. So according to this flow chart, I think almost 90% of the patients, 85 to 90% of the patients are non-reactive. Then comes this step of risk stratification. You have to risk stratify these patients into low risk, intermediate risk, or high risk. As I said, 3 main parameters: the clinical assessment of the patient, the exercise capacity of the patients, the RV function of the patient. 3 main parameters, 12 points. Risk stratify these patients: low risk, intermediate risk, high risk. High risk or very high risk, you directly go for combination therapy, and that therapy should include IV prostacyclin. Important. If the patient is high risk, very high risk, give prostacyclin, a combination therapy with IV prostacyclin. Then reassess the patient, again reclassify the patient as low risk, intermediate risk, or high risk according to his clinical condition after stabilization, and then decide the treatment. Now, as far as low risk and intermediate risk is concerned, you can either give a monotherapy or combination therapy. Well, we here at our center, and most of the centers in the world, they prefer combination therapy. Monotherapy has been, now monotherapies has been, it is now just for a selected group of patients, and they are very less, and you need to be really careful about that, because the guidelines clearly recommend a combination therapy in most of the patients. They are very selected group of patients which would really benefit by monotherapy, and these patients include those vasoreactive patients, or patients who have just functional class 2. Then this includes old age patients who won't be able to tolerate this combination therapy, or patients with comorbidities, multiple drugs, drug-drug interaction occurring, patient with milder disease having, say, HIV or pulmonary veno-occlusive disease, or patients having scleroderma. So very less number of patients would in fact classify to receive a monotherapy, and you should be cautious enough to select these group of patients for monotherapy. So going back to the chart. So after risk stratification, I think most of the patients, say 50 to 60% of what you had initially received, I think would receive the combination therapy. So you start with the combination therapy, and we'll be discussing after a few slides how the combination therapy works, which are the combinations available. Now this treatment doesn't end here. Now this is the drawback. This is what is followed in most of the most of the hospitals. They just start the patient on treatment, and then the thing ends there. But the important part, which has also been emphasized in the World Symposium Meet on Pulmonary Hypertension, is the reassessment of the patients. So after 3 to 6 months, you have to reassess the patients. Why 3 to 6 months? Because most of the registries, like the French registry, the Swedish registry, and the European registry, they have clearly shown that most of these anti-PH drugs, they start acting within 3 to 4 months. So you have to reassess the patient at 3 to 4 months, and it is at this point that you have to again re-stratify the patient into low risk, intermediate risk, or high risk, and ultimately further decide the plan of management in this patient. So this is again an important point which has been strongly emphasized in the World Symposium Meet also. Now, we were talking about combination therapy. Combination therapy is not very tough, and it's quite simple and straightforward. You have 3 major group of drugs. So for the basic principles of combination therapy include, you should avoid combining drugs from the same class. So do not use macitentan and ambrisentan together, do not use sildenafil or tadalafil together, because none of the trial or any data has shown improvement in patients while you are using two drugs from the same class. Riociguat is not to be combined with PDE5 inhibitors. Why? Because they would be both nitric oxide, acting on the nitric oxide pathway, and this can cause hypertension. Similarly, selexipag is not to be combined with prostacyclins, again because both act in the same pathway. Now, just a word about the trials. As I said, we'll be touching the pivotal trials in patients with pulmonary arterial hypertension. I think till recently, most of the trials in patients with pulmonary arterial hypertension, they were very short trials, had very less number of patients, and the endpoints were very soft. In the fact that they included the endpoints such as 6-minute walk distance or I think BNP levels. So most of the trials were very small trials and for a very short duration, and I think the results were not very impressive also. But recently we had three or four very good trials. They are long-term trials, almost trials of say 2 to 3 years, and the endpoints are hard points in terms of hospitalization and morbidity and mortality. And this is one interesting trial. This was a Seraphin trial, and it clearly showed the benefit of adding macitentan over and above the treatment the patient was taking. So actually this was the trial which emphasized the role of combination therapy, and it clearly showed that there was an improvement in the morbidity and mortality of the patients who were put on combination therapy as compared to monotherapy, especially when the patients were followed up for a long-term period of say. So another interesting study was this GRIFON study, and again it showed the benefit of adding selexipag to patients who were already on any monotherapy in the form of say sildenafil or tadalafil. Again, this trial showed the importance of combination therapy, and it clearly showed that combination therapy reduces the morbidity and mortality in patients with pulmonary arterial hypertension. Similarly, Ambition was a nice trial, again showing the importance of combination therapy versus monotherapy. This was a nice trial, randomized trial, which clearly compared patients on monotherapy with combination therapy, and it clearly showed improvement in morbidity and mortality in patients who were put on combination therapy as compared to monotherapy. Well, the newer drugs, now everyone is talking about there was similar excitement in all the members of the World Symposium in pulmonary hypertension. Which are the newer drugs which are coming for pulmonary arterial hypertension? Because these patients are really still have a very high annual mortality, and I will tell you there are several mechanisms that are being investigated, and newer drugs we are expecting in the next 4 to 5 years at least addition of 1 or 2 drugs in patients with pulmonary arterial hypertension. So these newer therapies, they involve drugs which are acting on proliferation, vascular dysfunction, the drugs which are acting on the bone morphogenic protein 2 gene. We have drugs which would act on metabolism, DNA damage, and also inflammation. So these are the group of drugs that are being actively investigated in these group of patients, and I believe in the next 5 to 6 years there will be at least addition of 1 or 2 drugs in this group of patients. So just to summarize what we have discussed in this complete meet, we now have a newer definition for pulmonary arterial hypertension. This definition was given by the World Symposium meet, which was held in Nice, and you should be aware of it because you can include more patients in pulmonary arterial hypertension, and that would really benefit those patients as you start the therapy early. There's an improved overall survival, but yes, there's a higher annual mortality. As we discussed, the annual mortality is as high as 15%, and that too in the Western population, it is much higher in the Indian population. We have newer drugs, but a proper approach to treatment is required to reduce the mortality in these patients. There's a strong rationale, there are trials, and there is data supporting sequential and upfront dual combination therapy. So combination therapy is the drug of choice, I would say, for this group of patients. Monotherapy is limited to very selected group of patients, and CCB is selected for a very less group of patients. It's just 5 to 10% of the patients with pulmonary arterial hypertension. As I said, vasoreactivity in these patients is really less. Regular and continuous assessment of patients is necessary. As I said, the first step as soon as you diagnose the patient with pulmonary arterial hypertension is risk stratification. The treatment starts from risk stratification. You need to be really aware of the fact that you need to risk stratify the patient, and once the patient has been risk stratified, you need to start the treatment according to his risk stratification. Second, once you start the treatment doesn't end there. The patient has to be reassessed, and it has to be reassessed every 3 to 6 months, because you need to re-stratify the patient after the patient has been put on treatment, re-stratify again him on low risk, intermediate risk, high risk, and decide the treatment accordingly. The high-risk patients, they should be offered parenteral prostacyclin as a part of combination therapy. This again we discussed. Remember, high-risk and very high-risk patients, they need to be given the combination therapy. And in combination therapy too, the IV prostacyclin has to be given in this group of patients. It really changes their overall morbidity and mortality. Triple therapy, well, there was a lot of talk in the World Symposium and in other conferences also about the triple therapy. So we have now clear-cut guideline for using combination therapy. Would there be a guideline in the future for using triple therapy from 3 different class? I think there are trials going on. There's a recent trial which is ongoing regarding the use of triple therapy as an upfront therapy in patients who are at intermediate or high risk, and we'll have results in the near future, which will decide whether to use triple therapy or not. So after this presentation, I think everyone must be ready to discuss an interesting case. So let us discuss an interesting case. This is a case presented by the institute, and let's see how better do we understand the patients with pulmonary arterial hypertension. So this was a 36-year-old male smoker. He presented to us with syncope. So he was basically a football player, and he was playing football at a ground and presented with syncope. So when he presented to our institute, as I said, how do you suspect pulmonary arterial hypertension? We did a ECG and echo, and ECG was suggestive of right ventricular hypertrophy, and echo showed a dilated RARV with a systolic PA pressure of 90. So at this point, this is the point where you clearly, need to refer the patient to a higher center. You are clear that the patient is having RVH, patient is having a dilated RARV, the systolic PA pressures are very high as 90. So he needs to be assessed by an expert to rule out why the PA pressures are so high. So at our center, we got a CT chest done. As I said, it was in the protocol. You have to rule out the group 2 and the group 3 diseases first. So he didn't have any group 2 or group 3 disease. So left heart system was normal, and the lungs were also normal on CT chest. So group 2 and 3 are ruled out. We also got a CT done. So there was no CTPH. So this group 4 has also been ruled out. Now we are left with group 1 and group 5. He had a dilated PA on CTPA, and there was a good finding what we found in CTPA. His right upper pulmonary vein drained into SVC. That is, he had a partial anomalous pulmonary venous connection. So RUPV was draining into SVC. Otherwise, everything was normal. So we ruled out the group 2, group 3, group 4. Now we are left with group 1 and group 5. We also performed right heart catheterization. So mean RA pressure was 7, pulmonary capillary wedge pressure 10, PVR of 10 Wood units, and since he was having this left to right shunt, we calculated the QPQS in this patient, and QPQS turned out to be 1.4. Okay. So the question for the audience: what is the diagnosis? What do you think is the diagnosis? Is it idiopathic PH with incidental finding of PAPVC? Is it Eisenmenger? Is it pulmonary arterial hypertension associated with this congenital heart disease? This congenital heart disease has causes pulmonary hypertension. Or is it completely something else which we are missing out? So I'll give you a minute to think over it. So I think the answer to this question is the patient is having idiopathic pulmonary arterial hypertension with incidental finding of PAPVC. Let me tell you that pulmonary arterial hypertension in congenital heart disease can be of just 4 types. So you can have just one of the 4. One is Eisenmenger. So this patient clearly didn't have Eisenmenger, didn't have any features of Eisenmenger. It can be pulmonary arterial hypertension with parallel left to right shunt. Well, the left to right shunt was not so prominent. I think it was just 1.4, and no other features of say increased right heart flow was found even in the childhood. There was no such symptoms. Then we have pulmonary arterial hypertension with associated small defects, which are coincidental findings, what we call. And finally, we have pulmonary arterial hypertension, which occurs in certain group of patients after defect correction. So clearly, this patient falls in this group 3, that is the pulmonary arterial hypertension with associated small defects. Next question for the audience: what do you think would be an appropriate treatment in this patient? 1. Start immediately the monotherapy or the combination therapy. Combination therapy preferred. 2. Drug therapy is contraindicated in this patient because he's having such complex disease, so no drug to be given. 3. You require an additional test or different approach. You need to reclassify a patient into some other category and then treat. And finally, none of the above. I'll give you a minute to think about it. So the answer to this question is additional test or a different approach. Why a different approach? Why additional test? So this is a beautiful, table from European Society of Cardiology 2015 paper on pulmonary arterial hypertension. And whenever a patient is having pulmonary arterial hypertension with associated some defect, which might be as small as possible, you need to see whether to correct the defect or not. So this is the first approach. If you have pulmonary arterial hypertension with some sort of defect, first see whether that defect has to be corrected or not. So you have to go back to this table, and you can see in all such patients in which there is congenital heart disease and there is PH, you need to see the PVR before correcting those disorder. So this patient had a PVR of 10, so that is quite high, and I think he becomes inoperable. So he is not to be operated, of course. So this is the additional approach that you have to apply in this group of patient in which there is pulmonary arterial hypertension with some sort of congenital heart disease before starting any drug therapy. Because if the patient is to be posted for surgery, the surgery is the first choice. You correct that disorder and then start the patient on treatment with pulmonary arterial hypertension. So for this patient, what we did was we classified the patient as having idiopathic pulmonary arterial hypertension with a concomitant small defect which was causing the left to right shunt. Then we risk stratified the patient. This patient fell into an intermediate risk according to his score. We gave him a combination therapy. There was a combination of MD-Centen with the Dalafil. We reassessed the patient. So we started him on therapy and then reassess the patient at 3 months. So this is important. You have to reassess. You just cannot leave the patient taking say a combination therapy for years and years. You have to reassess at 3 months. So we reassessed the patient at 3 months, and he was found to be in the same class. Of course, no surgery was required for this patient because already his PVR was 10 good units. Interestingly, we followed up this patient for I think almost 1.5 to 2 years. He remained in the same class, and we were reassessing the patient every 6 monthly. So after 2 years, what we found was he shifted into high risk. So he was initially at intermediate risk, doing good, low to intermediate risk, but after 2 years, he had heart failure and shifted to high risk. We stabilized him with IV prostacyclin and ultimately put him on endothelin receptor antagonist with PD5 and also Selexipag. So he is now on triple therapy. So this is how you can approach the patient. This was a case which shows how to approach the different group of patients with pulmonary arterial hypertension. Thank you all for your patient hearing. I would be really glad to answer any questions that the audience is having. Thank you.